Welcome back to the deep dive. We're jumping right in today with some medical revision notes that one of you sent over.
Yeah, this is great. The plan is to take this dense info and really boil it down, make it stick.
Exactly, like creating a high-yield study guide together, focusing on what really matters.
Mm.
And the topic is Meckel's diverticulum. Sounds technical, maybe, but it's actually the most common birth defect of the gut. Super relevant for pediatrics.
Absolutely. It's a classic, and it can be tricky because sometimes it does nothing, other times, big problems.
A real clinical chameleon, like you
Yeah.
said. Okay, let's unpack this. We've got the full picture here, definition, causes, symptoms, the lot.
Ready to go.
Yeah.
Let's build it up step by step.
Great. So first things first, the definition. What is a Meckel's diverticulum exactly?
Okay, so fundamentally, it's a small pouch or bulge sticking out from the wall of the small intestine. And it's congenital, meaning you're born with it.
Congenital. So it's from development, right? How does that happen?
Well, during fetal development, there's this tube, the omphalomesenteric duct, sometimes called the vitalointestinal duct, connecting the gut to the yolk sac.
Okay.
Normally, this duct just disappears completely, usually around the 6th week of pregnancy. But if it doesn't fully close off and vanish...
You get a remnant left behind.
Exactly. That remnant pouch is the Meckel's diverticulum.
Huh. Little leftover bit. And it's the most common one. That seems surprising for something relatively unheard of outside medicine.
Yeah, it really does highlight how often it causes no symptoms at all.
Hmm.
Location-wise, it's usually in the last part of the small intestine, the ileum. The notes mention about 2 feet away from where the small intestine joins the large one, the ileocaecal valve.
A few feet. Okay.
But here's the really, really crucial bit for understanding why it causes trouble. This pouch isn't always just normal intestinal tissue. It can contain ectopic tissue.
Ectopic, meaning tissue that belongs somewhere else.
Precisely. Most often, it's bits of stomach lining, gastric mucosa, or sometimes pancreatic tissue. Less commonly, jejunal.
Wait, stomach tissue. In the small intestine, doesn't that produce acid?
Bingo! That's the key problem. Stomach lining makes acid, and the small intestine lining isn't built to handle that.
Okay. That sounds like it could cause ulcers, bleeding.
You got it. That ectopic gastric tissue secreting acid is the main reason Meckel's causes symptoms, especially bleeding in kids. The acid burns the nearby normal intestine.
So that connects directly to the pathophysiology, how it works or how it goes wrong. It's all about that misplaced tissue.
Mostly, yes. The diverticulum itself is just a pouch. But if it contains that ectopic gastric or pancreatic tissue, that's the engine driving complications. Acid causes ulcers and bleeding.
Right.
But it can also cause problems just by being there. It can get inflamed, like appendicitis, it's diverticulitis. It can twist on itself, cutting off blood supply torsion. Or it can act as a lead point, pulling the bowel into itself.
Like a telescope in intussusception.
Exactly, intussusception. All of these can block the bowel obstruction or even cause it to burst, which is perforation.
Wow. Okay. So a range of fairly serious issues. And these notes also mention other related things like fistulas and cysts.
Yeah, it's all part of the spectrum from that duct not closing properly. If the whole thing stays open between the gut and the belly button, that's an omphalloidal fistula. You can get cysts in the middle part or sinuses at the belly button end. Sometimes just fibrous bands are left, which can also cause obstruction.
So Meckel's is just one possible outcome of that developmental glitch.
Pretty much. And it has its own blood supply, the omphalomesenteric artery.
Okay. Now, given it causes pain and bleeding, what else might you mistake it for? What's the differential diagnosis look like?
That's where it gets tricky, clinically. The symptoms overlap a lot. Appendicitis is a big one, especially the pain.
Right. Location can be similar?
Inflammatory bowel disease like Crohn's, peptic ulcer disease because of the bleeding, and of course small bowel obstruction from any other cause.
So you really need to keep Meckel's in mind, but you can't just assume. You need tests.
Definitely. Imaging and other investigations are crucial to sort it out.
Let's talk epidemiology then. How common is it really? Who gets diagnosed?
Well, the notes estimate it's present in about 2% of the population, though the UK prevalence isn't known for sure. Autopsy studies show a range, maybe 0.3% up to almost 3%.
So 1 in 50 people might have one.
Roughly, yeah. It tends to get diagnosed more in children and young adults.
Why then?
Likely because that's when complications are most common. And interestingly, when it does cause symptoms, it's significantly more common in boys than girls. The ratio mentioned is anywhere from 1:1 up to 4:1 male to female.
Huh. And the risk of actually having a complication over your lifetime?
Around 4%, according to these notes. And this is a really key point, that risk isn't flat. It changes dramatically with age.
Oh, How so?
It's highest when you're very young, peaking around age 2, then it drops off. By age 40, the risk is down to about 1%, and by age 70, it's approaching 0.
Wow, that's fascinating. So the danger is really front-loaded in childhood and early adulthood.
Massively so. And that has huge implications for deciding whether to treat it if you find one by accident, as we'll get to.
Okay, so clinical presentation, how does it actually show up if it's not silent?
Right, many are found incidentally during surgery for something else, or on imaging. But when symptomatic,
Pain, like the appendicitis mimic.
yep, abdominal pain is common, often vague or crampy, sometimes sharp and localized, mimicking appendicitis.
And the bleeding, you mentioned that's key in kids.
Absolutely. This is the classic. Painless, bright red rectal bleeding in a young child. Sometimes it can be darker, more maroon-colored stools too, but often bright red, and crucially, usually painless because it's from an ulcer, not a tear.
Painless bright red bleeding in a young child, got it. High index of suspicion for Meckel's. What about obstruction?
That's another big one. You get the typical signs: constipation, tummy pain, throwing up, if it's intussusception causing it.
A telescoping bowel?
Right. You might feel a sausage-shaped mass in the abdomen. And the classic description for the stool is red currant jelly, that stool mixed with blood and mucus.
Red currant jelly stools. Vivid. Another pattern to remember.
Definitely. Then there's diverticulitis, the inflammation which looks just like appendicitis but is rarer, and perforation, sudden severe pain, rigid abdomen, fever, very sick, plus the umbilical things we mentioned, fistulas, cysts. Oh, and rarely a tumor can develop in it, but that's uncommon, like 0.55% of complicated cases.
Okay, quite a range. Now, these notes have a great memory aid, the famous rule of twos. Can you break that down?
Yeah, the rule of twos is brilliant. It helps you remember the key stats. It occurs in about 2% of the population.
Okay, 2%.
It's located about 2 feet from the ileocaecal valve.
2 feet.
And it measures approximately 2 inches in length.
2 inches. Got it. 2%, 2 feet, 2 inches. Super useful. And diagnosis often happens when these complications kick off, right?
Often, yes. The complication brings the patient in, leading to investigations and finding the Meckels. And remember, complications are much more likely if there's ectopic tissue. That lifetime risk of needing surgery for a complication is put at 4–6%.
Right. So how do you actually investigate and confirm it? It really depends on what you suspect is going on. If it's bleeding, especially in a child, the test of choice is the technetium 99-meter pertectinate scan, the Meckel scan.
And why that scan specifically for bleeding?
Because that radioactive tracer, the technetium 99-meter pertectinate, is taken up by gastric mucosa, the stomach lining.
Ah, so it directly highlights the ectopic stomach tissue that's likely causing the bleeding.
Exactly. It targets the source. Very clever.
Makes sense. What about other imaging? If it's not bleeding, you suspect.
Well, an abdominal ultrasound is often a first step, just for general evaluation. A CT scan can be really useful if you're thinking about obstruction, like from volvulus or intussusception. It might show the diverticulum itself or the complication.
Okay.
Plain abdominal X-ray isn't great for seeing the diverticulum, but might show signs of obstruction or, rarely, an enterolith, a stone within the pouch.
Enterolith, okay.
For really severe bleeding, maybe needing transfusions, mesenteric arteriography can sometimes find the specific bleeding vessel. And the notes also mention wireless capsule endoscopy as a way to spot it, particularly in children.
So, a range of tools, but the Meckel scan is king for suspected bleeding in kids.
That's the takeaway, yeah.
All right. Diagnosis made or strongly suspected. How do you manage Meckel's diverticulum?
The basic rule, according to these notes, is pretty straightforward. If it's asymptomatic, found by chance, and doesn't have high-risk features, you generally leave it alone. No treatment needed.
Okay. But if it is causing symptoms or complications?
Then surgery is usually the answer. The goal is to remove the diverticulum and fix whatever problem it caused: bleeding, obstruction, inflammation.
And you'd stabilize them first, presumably, if they're bleeding heavily.
Oh, absolutely.
That's
Blood transfusions if needed, get them stable before any operation if possible.
Now, you mentioned high-risk features for asymptomatic ones. When would you take out an asymptomatic Meckel's?
Right. So the notes list clear indications for resection even if it's asymptomatic. Basically, if the patient is younger, say under 50.
Because the complication risk is higher then.
Exactly. Especially if the diverticulum is long, over 2 centimeters. Or if it has a narrow neck, making it prone to getting blocked or twisted. Or if there are fibrous bands attached. And critically, if you know or strongly suspect there's ectopic gastric tissue inside.
So it's a risk-benefit calculation. Taking it out electively in a younger person with those features might prevent a serious emergency down the line.
That's the thinking. weighing the small risk of surgery now against that higher lifetime risk of complications in that specific person.
And the surgery itself, is it open or keyhole?
The preferred approach nowadays, especially for symptomatic cases, is laparoscopic resection, keyhole surgery. It's generally safer, less invasive, quicker recovery, less costly.
Good to know. Are there risks with the surgery itself? Post-op complications?
Well, like any bowel surgery, yes, there are potential risks. The notes list things like bleeding after the operation, ileus where the bowel just stops working temporarily,
Right.
an anastomotic leak if two ends of bowel were joined and the joint leaks,
Yeah.
infection or abscess formation. And later on, adhesions, internal scar tissue, which can cause bowel obstruction months or years later.
Okay. What about medications, antibiotics?
Yes, antibiotics are used, but mainly as backup for surgery. If there's perforation or peritonitis infection spread inside the abdomen, then you definitely give antibiotics.
But they don't treat the Meckels itself.
No, they treat the infection alongside the surgery. The notes mention choices depend on local guidelines, but give examples like cefotaxime, clindamycin, metronidazole, broad cover for gut bugs.
Got it. And just to summarize the non-medication side again.
Yep. Asymptomatic, no high-risk features, leave alone. Found incidentally during surgery in kids, young adults, often removed. Symptomatic, excise the diverticulum, bleeding, might need to remove a bit of the opposite bowel wall too, obstruction from adhesions, divide the adhesions, perforation peritonitis, might need a bigger resection of the affected bowel segment.
Clear. Okay, what's the general outlook then? The prognosis.
Generally, it's good, provided it's managed appropriately. If it's asymptomatic and left alone, prognosis is excellent. If it's symptomatic or complicated, the outcome really hinges on successful surgery and managing any complications quickly. So timely intervention is key if problems arise.
And let's just quickly recap those main complications one last time, as the notes have a dedicated section. The big hitters are...
Right, the ones to really remember. GI bleeding can be mild, can be massive. Diverticulitis inflammation, intestinal obstruction, twisting, telescoping bands, perforation leading to peritonitis, and intussusception, the telescoping itself.
And these often need urgent treatment.
Absolutely.
Yeah.
And again, much more likely if that ectopic tissue is present. That lifetime risk of needing surgery for one of these is around 4–6%.
Okay. Wow. We've covered a huge amount, all from these listener notes, from the embryology, the sneaky leftover duct, to the ectopic tissue being the main villain, the different ways it presents mimicking appendicitis, that classic painless bleeding, the red currant jelly stool.
Don't forget the rule of twos.
Definitely not. 2%, 2 feet, 2 inches. And that really striking age-related risk influencing who gets surgery even without symptoms.
Yeah, connecting the dots from the basic science to the clinical picture is crucial.
So thinking about everything we've discussed from these notes on Meckel's diverticulum, what's the most sort of thought-provoking thing that stands out to you?
For me, I think it's that paradox you highlighted. It's so common, yet mostly silent. But it holds this potential for really serious, sudden trouble, especially in the young.
Yeah.
And the fact that clinical decisions, like operating on an asymptomatic young person based on features like length or a narrow base, really highlight this proactive risk management. You're intervening based on future probability, not current illness. That's quite a profound aspect of medicine. Deciding when not doing something is riskier than intervening.
That's a great point. It's managing a hidden risk, a potential future emergency based on statistical likelihood and anatomical features. It really sums up the complexity behind what might seem like a simple leftover pouch.
It really does.
Well, that wraps up our deep dive into Meckel's diverticulum, all thanks to the excellent revision notes shared with us. Hopefully breaking it down like this has made it clearer and more memorable for you.
Yeah, hopefully really high yield.
And if you are revising for exams, maybe like the MSRA, or just looking for solid medical resources, notes mention checking out sites like passthemsra.com and also freemsra.com.
Sound like useful resources for sure.
We genuinely enjoy digging into the sources you send us. If you've got something you want unpacked, do let us know. Until next time, keep thinking, keep learning. Thanks for joining us on The Deep Dive.